Hello, everyone. My name is John Mooney. I'm the founding editor of NJ Spotlight News, and welcome to this certainly very timely and important discussion we're having on living with COVID, pandemic to endemic, or at least we hope so. This is part of a series that we've been doing digitally on our site and hope to continue, plan to continue in virtual roundtables as well. We started last week with a series of stories about living with COVID and the implications on the long term. And we will be doing a number of roundtables like this one. The next one will be focusing on mental health issues coming out of the pandemic for all ages, and obviously a very important topic going forward. Bunch of logistical things I just want to go over. Attendees, certainly I know a lot of you submitted questions when you registered, and we'll be trying to incorporate those into the discussion as well. Um, but you can also submit questions in the Vimeo Q&A window, and we also encourage you to use the chat function in the Vimeo. Unfortunately, we can't be together live and in person, but we found that the networking in the chat is also great. As I've often said, what's a virtual roundtable without hashtags? And in our case, it's living with COVID NJ, one word, with the tag of NJ Spotlight News. Basically, how this is going to work is we are going to have a keynote talk by Linda Schwimmer, the CEO of New Jersey Healthcare Quality Institute, to give us an overview on the issue. And then we'll have a panel discussion. And included on that panel is Dr. John Bonamo, the Executive Vice President and Chief Medical Quality Officer at RWJBarnabas Health, Dr. Eddie Bresnitz, the former medical advisor of COVID-19 response for the New Jersey Department of Health, and the former state epidemiologist. And for those who have followed the governor's press briefings around COVID, Dr. Bresnitz should look familiar. Has been a frequent attendee and really been a great voice and source of information. Robin Cogan, a school nurse with the Camden City School District and legislative co-chair of the New Jersey State School Nurses Association. Thank you for joining us, Robin. And Dr. Denise Rogers, Vice Chancellor for Interprofessional Programs, Rutgers Urban Health and Wellness Institute, and Director of Rutgers Urban Health Institute. Dr. Rogers, thanks so much for being here. And our moderator today will be Lilo Staton, our longtime healthcare writer, and really has led our coverage for the last 2 years, and I'm amazed she's still going. It's been an incredible ride and incredible journalism from Lilo, and we're thrilled to have her leading us. Before we start the program, I also want to introduce Steve Shallett, our Business Development Director, who's going to say a few words about our sponsors. We couldn't hold this event for free without having the support of our sponsors. And we very much want to thank and appreciate their work. So take it away, Steve.
Thanks, John. I'm Steve Shallett, Business Development Director for NJ Spotlight News. It's my privilege to be the producer of today's event. Thank you so much for joining us. As John mentioned, it wouldn't be possible to bring these events to the public free of charge without the gracious support of our sponsors, whom we would like to acknowledge with our thanks this afternoon. First, RWJBarnabas Health. RWJBarnabas Health is the largest, most comprehensive academic healthcare system in New Jersey, dedicated to providing high-quality patient care, cutting-edge research, and world-class health and medical education to advance and transform healthcare in New Jersey. RWJBarnabas Health has long been committed to improving health outcomes, promoting health equity, and eliminating healthcare disparities. With the COVID-19 pandemic bringing social and racial inequities to the forefront of public health, the system accelerated its efforts to educate and support vulnerable individuals and communities throughout the state. During the height of the crisis, RWJBarnabas Health responded to meet the critical and emerging needs of its patients in disenfranchised communities, working with partners to distribute food, masks, and other supplies, organizing community COVID testing and vaccination sites, and going door to door to educate community members about the virus and ways to stay safe and healthy. So thank you very much to RWJBarnabas Health. Next, we'd like to thank NJEA. the New Jersey Education Association. It's a diverse, democratic organization that works to create an optimal environment for achieving excellence in public education in New Jersey. NJEA's mission is to advance and protect the rights, benefits, and interests of its members, and to promote an excellent system of public education for all students in the state. NJEA promotes and delivers quality professional development for educators and advances and supports policies that enhance and enrich public education. So thanks again to our sponsors. We'd like to begin our program today with a keynote statement from Linda Schwimmer, CEO of the New Jersey Healthcare Quality Institute. Linda's remarks today will cover highlights from Emerging from COVID-19, an action plan for a healthier state, which is a set of recommendations created jointly by BioNJ, the Life Sciences Trade Association for New Jersey, and the New Jersey Healthcare Quality Institute, a state and nationally engaged nonprofit healthcare improvement organization. We will drop the links to this report in the chat today, and we'll also email them to all registrants after the event. And with that, please welcome Linda Schwimmer.
Thank you, NJ Spotlight, for having me today. I know that I relied on you and your professional reporting throughout the pandemic, as many others did, to get the information and the stories that we needed. I'm so honored to be here today to be able to discuss the Quality Institute's work on its action plan for emerging from the COVID-19 pandemic. And now is the perfect timing to be having this panel discussion about how we move from a pandemic to an endemic state. And I appreciate you focusing on this important topic. 2 years ago, and it's incredible to think back at the fear that and the feeling of isolation and the unknown that we were all experiencing as the virus reached New Jersey. I remember that day really clearly. I was picking up my father-in-law from a hospital in Bergen County to get him out of there as quickly as possible, and just a day later, it was announced that the first cases of COVID were found here. As the virus surged, so many of the Quality Institute's members reached out to us to talk about what they were seeing and facing and how they were adapting to respond to the pandemic, and urged us to start to capture some of the work that they were doing and the lessons learned, so that when we finally reached this point where we weren't in a constant state of reacting to the emergency, but could step back and think about how we emerge and how we want to work towards a healthier New Jersey, that we would have those lessons captured and those thoughts memorialized from everyone's experience. So that is really exactly what we did. After the first surge, we pulled together a group of people who were working across community organizations and healthcare organizations, as well as interviewing people at all levels of public health to really understand what they were facing and to capture their lessons. We then did what one of the things the Quality Institute does best. We convened all of these individuals and organizations to discuss the issues. And from that, we put together an action plan, which consisted of 4 main high-level steps to take at this moment in time. And I'm really pleased and honored to be able to share those with you at a high level today, and then urge you to read the action plan. And I'm also looking forward to the discussion following my remarks of the panel, because this is a moment where together we can really take the lessons that we've learned, and just like in other past pandemics, expect and work on significant social change together. So the high level actions that we all coalesced around were as follows. The first one was really looking at the healthcare workforce. We're concerned that we don't necessarily have the healthcare workforce that we're going to need as we move into the future, particularly with an aging population. We also know that our healthcare workforce over the past 2 years has experienced significant trauma and stress. And so it's going to be very important to address their mental health, which is going to mean really destigmatizing mental health, supporting it financially, making mental health supports and services available. And that's going to take further investment and integration of that type of care throughout primary care as well. We also need to have a better handle on the current healthcare workforce that we have today, which means having the data to know what the healthcare workforce looks today, and then how do we improve the licensing and the credentialing systems and really get that diverse healthcare workforce that we need for our diverse population. The second area that we focused on is really the healthcare delivery system and payment structure that we need for the future. And that needs to be one that has a primary care base where everyone has a trusted primary care provider, be it their pediatrician, a physician, or a nurse, but someone within their community that they can go to for their public health information and they can go to in times of stress and emergency, as well as one that, again, is diverse and culturally congruent and that they feel comfortable with and they trust. That means investing in that system, and that means investing in that system across all types of insurance, including Medicaid, which really underpays primary care right now. And then really utilizing technologies and, again, the healthcare workforce to meet people where they are. So whether it's through telehealth, remote monitoring, home health, and helping people age in place, a healthcare delivery system that really is more accessible to people and how they live their lives today. A third and really important pillar of the work was looking at social determinants of health and equity. We saw, and NJ Spotlight really highlighted this through a lot of its charts and a lot of its reporting, that COVID's impact really hit New Jersey differently, and the death and hospitalization rates were much higher for certain sectors of the population, particularly Hispanic men in their 30s and 40s and Black New Jerseyans. So a lot of that was directly related to things like housing, jobs, whether or not you had earned sick time off, other resources, your environment that you live in. All of these issues, just like in other pandemics, we need to invest in the changes that need to be made so that we don't have this level of disparities that we saw. And then finally, and critical, is our investment in public health. Public health has often been ignored, and then it pops up as a critical issue in times like this. And it's time to break that cycle and to really invest more in public health, to modernize it, to give it the data that it needs, and most importantly, to connect it to both the healthcare system as well as to communities and places where people go and trust. Whether it's their churches, mosques, synagogues, their senior centers, really public health needs to be connected to the places that people already are congregating and getting their information, and needs to be a hand-in-hand partner. And that's going to take resources at every level of public health. So as you can see, we had some really robust and fruitful discussions on the future. I'm excited that now we can finally get to that work. I encourage you to read the action plan. And again, I'm really thankful to NJ Spotlight for being here for all of us and for creating this opportunity and space for this important discussion at this moment in time. So thank you, NJ Spotlight, and I look forward to the panel.
Hi, I'm Lilo Stainton, healthcare reporter for NJ Spotlight News. I know some of you are just joining us now. I encourage you to go back and listen to Linda Schwimmer's presentation. She pointed out, they've done a study that pointed out a number of the things that are really important lessons coming out of the pandemic. Thank you for joining us today. Here we are living with COVID as we go into what is truly a third year living with a novel virus. We have come a long way in the past 2 years. We have seen, incredible bravery and selflessness. I would argue we've also seen some selfishness, some anger, and plenty of division. And we've also experienced, I think, many people, unbelievable anxiety, grief, frustration, depression, emotions that sort of on scales that we are not used to as individuals and as a nation. And I'm glad, mental health challenges were one of the things that Linda's team flagged. New Jersey diagnosed nearly 2 million cases of COVID, and that is surely an undercount. Some suggestions are it could be twice that high if everybody had been tested when they were actually sick. We have nearly 33,000 deaths in New Jersey. That is a death rate, COVID death rate, that I believe is twice the rate for heart disease and cancer. Both of them, and those are the two top killers in New Jersey. We have learned a lot. We will talk about some of these things, about racial gaps, about workforce needs, about the importance of the public health system and where it is falling short. And some things are good news, like telehealth and how it can actually work better than we thought. We're at a point now where cases and hospitalizations are coming down significantly. And there is a real suggestion, I think, among leaders, but also the public, this desperate need to move forward and move from what everybody is saying a pandemic to what people are calling an endemic state. But yet we had nearly 1,700 new cases today in New Jersey, 400 plus people remain hospitalized with COVID in this state. There were nearly a dozen deaths in hospitals reported this morning, and there are new variants raging overseas. So the question is, how do we go forward and how do we navigate this new landscape? And I'd like to start with states. I'm going to do a short introduction in case anybody missed it before. Dr. Eddie Bresnitz, the state's former epidemiologist. He's worked at Merck on vaccines and also helped the administration during the recent pandemic. So, Dr. Bresnitz, thank you. Tell us, what does endemic really mean, and are we at that point now?
Well, we've been talking about the pandemic, which means a disease that is involving people around the world, a global problem. And frankly, I still think that we're in a pandemic. I don't believe that we're in an endemic phase just yet. Because what we've seen over the last couple of years, and it's about a little over 2 years now since the first case was reported in New Jersey, and a little bit longer in the U.S. What we've seen is a roller coaster ride of increasing and decreasing incidence over that time period, with the most recent surge being the highest of all the different surges. If you could put up that graph that I showed that provided to you, and I apologize for the handwriting there. What you see here, and this was prepared, at least the graph itself was prepared by the Communicable Disease Service in the Department of Health, but I take responsibility for the sprawl. And what these are confirmed COVID-19 cases as diagnosed by PCR. You'll see that the label on the left says plus probable. I just wanted to put that there to indicate that there are more cases than that, as Lilo indicated. Those cases are considered probable and reported as such by the Department of Health. But there's also all those cases that people have where they've done home testing. And what I want to show here, what I want to emphasize here, is the ups and downs of the disease incidence over time. And you can, and I've tried to put in there, I have put in there where it corresponds with the predominance of various variants, alpha in the middle, delta towards the right side, and then the most recent surge with Omicron, where we had over 33,000 confirmed cases and many more probable cases as well. And then we've had, so it was a dramatic surge, and then it came down. And it was declining up until today when there were 1,500 plus cases that were confirmed cases that were reported. But I want to point out that in conversation with the Department of Health, that was an artifact. That 1,500 cases actually represents, about 2/3 of that actually represent cases that were diagnosed in December and January, but there was a reporting delay from one of the commercial labs. And so the cases that were more recently diagnosed, those were about 500 then. So the trend is still downwards, but based on that graph, I think you can appreciate that we really don't know where this is going. And we also heard that there is increasing incidence of cases in Europe, in various countries, the UK, and Germany, and Italy. And in the past, we've seen that they are forerunners for potential increase in cases in the U.S. as well. And we have seen another lineage of the Omicron, that what's so-called BA2 lineage, is increasing percentage of all the tested cases in the U.S., including in New Jersey. So I personally can't say that we're in an endemic phase just yet. I think we're still in the middle of a pandemic. And that's true for places in the world where a lot of people are unvaccinated.
So that's interesting. So if we're not yet in an endemic phase, I'm going to ask school nurse Robin Cogan, who is a leader in the School Nurses Association in the state. It's been 10 days ago we lifted the mask mandate statewide. I believe the Camden district where you're working, they're still masking there. What is the current situation in schools, and with or without masking? How do you see things going right now?
So it's interesting because, first of all, thank you for inviting me to this and being part of this conversation, because what happens in schools is so important for people to understand. What we've seen in terms of transmission within schools, there has been transmission in schools, but ultimately it was community spread that came into schools, spread within families, within close contacts within families that came into schools. However, within schools themselves, the spread that we saw were most often happening in times when masks were not worn. For example, lunch, sports, anytime there were, large groups of people together unmasked, that's typically, if we had outbreaks, it would be during those times. So the landscape in New Jersey is very different because every district now, 600 of them, are choosing, kind of cherry picking, which guidelines are going to follow since the mask mandate was lifted. Almost immediately, many school districts then lifted many other things that they were doing to protective factors in school. So that has been very concerning. It's concerning to school nurses because we have really good information about what works in school to reduce COVID transmission, right? We know it's vaccination, ventilation, and masks. And so when masks are taken away and vaccination is lower than we would like it to see, and ventilation is still something that we need to have a robust conversation about. What do we have left in terms of protection? And while it's really important to talk about off-ramps and what do we do moving forward, will we be ready when the time comes, and it may be coming, for on-ramps? For those districts that are removing everything, how do you then put them back? So those are just some things I wanted to raise around what's happening in schools.
I'm glad you mentioned that. That was actually one of my questions later. When you pull these things off, how are administrators going to be able to put them back? And I think it's important that you note, if it's community spread that is driving, cases in schools, and every school has different policies, there's going to be different impacts. I mean, community, it's going to be interesting to measure these impacts going forward. Dr. John Bonamo is with us from Robert Wood Johnson Barnabas Healthcare System. He is a vice president whose exact title I don't have in front of me, but it's very long and very important. And sorry, Dr. Bonamo. But seriously, tell me, how are hospitals doing today? Barnabas is a huge system. More than a dozen hospitals, I know. I've lost count of the exact number, but a lot of systems there, a lot of patients, a lot to learn.
So, Lila, thank you. Our numbers are down dramatically from our peak on January 11th, which was pretty much the Omicron peak throughout the state. We're down about 94%. As far as inpatients are concerned, we had 1,275 patients in our hospital beds for treatment for COVID-19 in January, and now we're down to less than 100. However, that number has stayed pretty stable for a week or so. We're looking forward to seeing it certainly decline further. But while I have the floor for just a moment, I'd like to really agree wholeheartedly with Dr. Bresnitz on the fact that I don't believe we're in an endemic phase yet. I think perhaps we have declared that too soon because we're hopeful to be there. And for lay people who may be listening to this, I don't know if we've really defined endemic, right? So endemic is when people can get treatment for something, that the system can handle it, but there's consistently low numbers of people affected. And I don't know that we're there. I think it's still too soon, as Eddie said, to declare this. I think there's no hard and fast rules. And the thing that people have to know, and I worry about celebrating too soon and people not doing the things that we know are helpful, because even in an endemic phase of a disease, people still get sick and people still die. And so we are unfortunately have missed the boat on eradicating this disease. We maybe could have, but we did not. And that was the country's choice and people's choice. But now we have to live with managing it. And declaring it over too soon is a great way to have it become unmanageable again. And so I just wanted to weigh in on agreeing with Dr. Bresnitz on that topic.
No, I'm glad you mentioned that. And I was thinking an endemic disease, we think of the flu as endemic. And I know that Dr. Lifshitz, who heads the Communicable Disease Service at the state, gave us the numbers recently for the number of deaths on an average flu year. And I'm not remembering exact. Dr. Bresnitz, can you give us an example of what the deaths are from a flu in an average year in New Jersey?
Well, pre-pandemic, New Jersey, I'm not quite sure. A rough guesstimate might be, I'm going to say maybe 1,500 cases.
I think that's what he said. I think that's what he said. I was hedging, but yeah.
In the U.S., it's about 50,000 per year attributed to flu, and ballpark when you're looking at New Jersey is 3% of it, whatever the national number is. And again, I do want to. The flu is a good example. We have a low level of disease, from April through to September, October. And then we have a typical surge in what we call the respiratory season. And we consider that to be endemic in a way, but there's a sort of an outbreak, if you will, during the winter season. That's true with other respiratory pathogens as well. And so it's what we expect. I guess the way to think of it, there's no good definition of endemicity. I tried to look it up several times over the last few months. I don't think anybody has a really good definition of it, except I would say that it's a certain expectation of what the disease incidence will be over time. Pretty much for me, that's what it is. And so when you go back to the graph that you showed, there was no predictability beyond what we were going to see around the corner when we had a nadir of disease. We didn't know what was coming next. You recall that first summer, we thought we were in good shape and expecting to maybe have some change in the fall. And it came, and then it came with a vengeance subsequently.
And in some cases, it seems as though what we were hearing from other nations when it came to Omicron, the information wasn't useful or wasn't used. That's a conversation for another day, in a way that really benefited us. So how we know what these variants might do, it's hard to say. Dr. Denise Rogers from Rutgers University, Believe in a Healthy Newark, vice president. I forget your exact title as well. Excuse me. But please tell us from sort of a community health point, what do you see in Newark? What do you see in sort of on a local level in New Jersey? And are we at endemic yet, in your view?
So we're definitely not in an endemic phase. Like Dr. Bresnitz, I actually went to the CDC website and looked it up, and they describe endemic as the amount of disease that's usually present in a community. And quite frankly, because COVID is a novel virus, we actually don't know what the endemic state is going to be. We certainly could imagine that it could be similar to what we saw last summer when we had many, many days under 200 cases. But I am in complete agreement that we're not in an endemic state right now. In terms of what we're seeing in the community, I think a lot of what we're seeing in communities like Newark it is not necessarily that different than we're seeing in other communities around the state, which is a lot of confusion because we're giving extremely mixed messages right now. So we're saying you can take your masks off, it's fine. We're saying, sort of go back to life as you used to live it, sort of pre-pandemic. And yet, we are not, in my opinion, at a rate of cases that really warrants quite that level of sort of optimism and throwing caution to the wind, if you will. We haven't yet talked a lot about vaccines, but we are still having significant problems getting people to get boosted. And the more we say to people, it's over, don't worry, the more reluctant people are to get boosted. We're also hearing in many communities a reluctance to get children vaccinated, related to both safety as well as, well, if this is over, then why do I need to get my children vaccinated? I would say that part of the biggest challenge that all of us face who are trying to do this work is to be able to acknowledge that in an instance like a disease like COVID, there are some things that we just don't know. And our recommendations change as we learn more. But what we also know is the virus changes. And that's really hard for people to sort of come to terms with. And so I think there's just a lot of confusion out there right now.
So, yeah, and I think from what I understand, misinformation, I mean, the U.S. Surgeon General produced a whole report on the danger of misinformation and how bad advice is putting people at risk. Let's take this chance to give people some suggestions on where they can get good advice. I don't know who wants to go first, but I did warn folks. Robin Kogan, can I come to you first?
Sure. Well, I like to share, of course, evidence-based advice with our families. And several that I recommend, one is through certainly by the American Academy of Pediatrics. HealthyChildren.org is a fantastic website. Lots of COVID-19 information for families with young children and adolescents, children with special healthcare needs. They've really covered so many aspects of COVID that impact family life. They talk about ADHD and learning during COVID, what to ask your pediatrician regarding COVID, breastfeeding during COVID, and certainly a lot of really good information on vaccine checklist. Unfortunately, there were a recent study showed that the Pfizer vaccine for ages 5 to 11 was less than robust than had been anticipated, especially related to Omicron. So there are so many, you're right, there's a lot of confusion out there. And yes, misinformation, but also we have to be honest, there's also disinformation. There's targeted wrong information out there that is really frightening to families. And depending on where parents are getting, their news, their information, they could be accepting things that are not true as fact. And it makes it very difficult to try to, encourage people to get vaccinated when there's so much wrong information floating around out there. So that's a big one that I recommend. Lots and lots of really great articles to read in multiple languages also.
Anybody else?
Yeah, Lila, I think Robin's right on talking about, when you're talking about the children going to the pediatric literature. I think one big question out there for people thinking about vaccines and thinking about boosting is women in the reproductive age range. So women are worried about if they're pregnant, if they want to become pregnant, if they're nursing, etc. They need the vaccine and the boosting more than anyone else. Pregnant women get sicker than everyone else. Pregnant women die more often than anyone else, than the general population with COVID, anyone else. And so I would suggest to young women who are interested in childbearing and all things related to childbearing, and what the specialty societies say about it, they can go to the American College of Obstetrics and Gynecology website or the American Society for Reproductive Medicine website. Those are the specialty societies for infertility and for OBGYN, respectively. And they have all of the information and all of the studies on pregnant women and women in the reproductive age range that I think could be very, very helpful to them.
And we are definitely going to talk about vaccines. I know we have a lot of questions about vaccines.
Lila, just 1 second.
Yeah, please.
I'd be remiss if I didn't recommend the public health sites, in particular in New Jersey, the Department of Health's website for information. And I'm going to also recommend the CDC website, although, it really has a ton of information, and sometimes it might be a little bit difficult to find what you're looking for if it's something very specific. And I know there's been a lot of controversy on some of the policy recommendations that the CDC has put out from a perspective of timeliness and perhaps sowing some confusion because of the changing recommendation. But I think that reflects the changing knowledge base that policy decisions are made on. But in reality, there is a fantastic amount of information there, both geared towards the health professions as well as the public. And I think that's important because some of the material geared to the health professions is not something that can be absorbed easily by the public. But I frequently, when asked by my family or friends for like what's going on, I cut and paste things out of the CDC site and I send that to them because I think that's really the most current. And of course, the Department of Health very often follows the CDC, as do other state health departments. But of course, they have their own policies depending on whatever policy decisions are made within the state.
Yeah, I think that's a really good point. I would also say that I've been surprised at how accessible some of the information, a lot of the information on the CDC site, and even some of the, the Academy of Pediatrics, American Academy, some of those sites, they really do have sections that are designed for the public. So I recommend to people that, don't be afraid just because you think it's for doctors or something. Some of them are very good.
Lilo, I'm sorry, but I have to put in one more plug.
I was going to do it if you did. Go for it.
I chair the steering committee for an organization called Believe in a Healthy New York, and we have a website as well as a pretty extensive social media presence. And part of what we attempt to do is actually translate a lot of the information that comes from CDC or from the Department of Health into lay language. And so I would encourage people to look at BelieveInAHealthyNewYork.org. We have Twitter feed, Instagram, TikTok. But the other advantage, I think, that we have at Believe in Healthy New York is that we also have resources about where do you go to get food and what do you do if you need rental assistance? Because you can't talk about the COVID pandemic and talk about the disease itself only, because obviously this pandemic has had an adverse impact on people at many, many levels. And I think, Linda Schwimmer in her opening talk really addressed this whole issue of social determinants of health. And so we also have to give people resources that can help them to deal with some of those issues as well.
Yeah, I visited your site the other day, and I have to say I was very impressed. I had wished I had been seeing it sooner. I'll just leave it at that, because it had a lot of really practical information. So thank you for that. We have gotten several questions in the chat, and there are questions many places about treatment. And what kind of treatments are available now. There seems to be sort of a hopeful sense that there are new over-the-counter treatments, not over-the-counter, oral medications that you can get at a pharmacy, outpatient treatment, not as opposed to an inpatient infusion. Dr. Bonomo, I'd like to start with you. What is Barnabas seeing? How are you treating patients, inpatient, outpatient? And what do you see these treatments? I mean, what kind of a change is this for people?
So it's a massive change from 2 years ago when we had nothing and we were using things that we now know wouldn't help at all. However, now we have things that are very helpful. And we have good inpatient treatment, and we know to use steroids on patients. We know not to jump to put patients on ventilators right away, to use something called high flow oxygen, allow them to have something called permissive hypocarbia, which just means their oxygen level's a little bit lower than you might normally tolerate, because the patients do well with that. About 14, 15 months ago now, we had the first monoclonal antibodies that were infusions, not for inpatients, but had to be done in an emergency department setting pretty much. And we at RWJ Barnabas Health started, they came out in November of 20, and we started probably 2 weeks after they were released. And we've done we're just about to hit 19,000 patients who we have infused with monoclonal antibody in our emergency departments. However, that number has only gone up by 400 or 500 in the past month, because now the oral treatments are available, as you mentioned. There are two products that are on the market. One is a Merck product, one is a Pfizer product. The Pfizer product has the same success rate of keeping you out of the hospital and keeping you from getting very ill if you contract COVID as the monoclonal antibody infusion. So it's an oral product that has the same efficacy as the IV product, which is great news. The slight problem with the Pfizer product is there are some drug-drug interactions, some common medications that people are on that it makes them not a candidate necessarily for the Pfizer product. We did worry early on that there wouldn't be enough Pfizer product, but since the incidence has declined to the point where we are, there is enough for people to avail themselves of it if they need it. The Merck product does not have the same efficacy rate. If there's nothing available, the Merck product is still fine, and it's used by many people. But the efficacy rate of staying out of the hospital and staying getting a little bit sicker is the profile is not as good with the Merck product as with the Pfizer product. But it's I think we're lucky to have all these treatments now. As I said, 2 years ago, we were grasping at straws and doing things that we now know just don't. Didn't work then, it wouldn't work now.
Right. And my understanding is the Pfizer, is it Paxlovid or something like that, maybe? Yeah. Is extremely effective. I mean, almost 8 out of 10 patients would be kept out of the hospital. And from my understanding, it is literally you stay at home and you take it over the course of 5 days, like Tamiflu or something. So the individual is not traveling around. They're not coming to a place while they're sick. They are home recuperating, taking this medication that they got theoretically at a drugstore. But are we there yet? That's my next question. And I don't know, Dr. Rogers, can you talk a little bit about, I know the president rolled out or talked about a new program, Test and Treat, and we're getting some questions about it now. Is it possible to go to a drugstore and get it? Do you have any sense of that at this point?
Well, certainly, it's not my sense you can just sort of go walk in and get it. One of the big concerns I have is I think that there's misinformation about whether you have to pay for it. And right now, there continues to be subsidies so that you don't have to be insured or have coverage for your medications. And I think many people who are vulnerable to adverse outcomes from COVID aren't aware of this. So we need to do much more about that. I think the whole test and treat gets into this issue of will a home test do, and how do you prove your positive test? And so I find the catchphrase to be a lot easier than the reality of what it takes to actually do this at the community level.
Yeah. Dr. Bresnitz, I'm going to come to you. I know we had a little discussion about this. There are some practical implications here. It does require a prescription. It is not over the counter. I apologize. I misspoke. It is an outpatient treatment that you can get by prescription that theoretically could be available as another treatment is like an antibiotic or something else. We're not quite there yet. Dr. Bresnitz, I don't know if you want to talk about the issues with test and treat, but I really want to get into the vaccines.
Yeah, so briefly, I mean, the good news is, that there are these treatments available throughout the state. At the beginning, when they were first authorized, they were very limited supply, particularly in relationship to the incidence of disease, so the burden of disease. There just wasn't enough to go around. But I checked in with the Department of Health, and there are plenty of all these different drugs available around the state. In fact, you can go on the Department of Health and Human Services site, in the Assistant Secretary for Preparedness and Response website, and you can click on and find out, just by putting in your zip code, which pharmacies have what product in your area. So they are available, and that's thanks to the fact that it's been made available. And as Denise said, that it's at no cost to the individual. But I share her concern about access, and for a lot of different reasons. But the other issue is that particularly for the oral drug, and also for one of the IVs, Sotrovimab, you have to basically get it within a certain number of days from the onset of first symptoms. So for the oral medications, it's within 5 days. And so think about it. An individual has to, number one, realize that they're having symptoms. Number two, have to have available test kit or get access to being tested. Number three, when it's positive, they then have to have access to a physician or a clinician who can write a prescription, not necessarily a physician, who's authorized to write a prescription. And then they have to get the prescription filled. Around the state, there are, as I said, many sites that have many of these different drugs, not necessarily one of them, but they don't all have the ability to test and treat. And my understanding is a little over 40 of the 400 plus sites that have one or more of these medications actually can test and treat, which means that they have a clinician there who can actually write a prescription and evaluate the patient before they write prescription to make sure that there's no contraindication for them to get that particular drug. There's also an algorithm available through the Department of Health and Human Services, again, that can guide a clinician on to which medication to use depending on when they were diagnosed, what their age is, what their renal and liver function are, and so on. So the key thing is access to tests, getting tested quickly, and getting access to physicians or health providers to write a prescription that they can basically have filled at the pharmacy. And the test and treat program, by the way, is not just at pharmacies. It's also community clinics, federally qualified health centers that have them available, long-term care facilities, and some other settings as well. And finally, providers really do need to read the prescribing information, because not all the products are similar. There are contraindications that differ between the products. And the indications differ for who can basically make the products available. Sorry, the indications may differ for different people.
Right. It seems as though, it could have real power in a place like long-term care facilities, where, residents are it's easy to test people. It's easy to get prescriptions. It's easy to get, medications there. We're running a little short on time, so let's talk about vaccines. It's like the V word here. We've gotten questions, if I had a lung disease or a lung transplant, do I need a second booster? When will we need a second booster? Will we need boosters forever? And then there's the whole question of children, which we'll put aside for 1 minute. But let's start with adults. And Dr. Bresnitz, I'm going to keep you on the hot seat. Where are we, and how important are vaccines at this point in the transition from pandemic to endemic?
Well, vaccinations with any one of the COVID-19 vaccines that are authorized or approved by the FDA and recommended by the CDC are the foundation for all our preventive measures, frankly. And number one is making sure or improving, if you will, the primary vaccination rates among the population. We have, I think, about maybe 3/4 of the population that have primary series, but only about half of them have gotten the booster dose. Then we have immune-compromised patients whose primary series is really 3 doses, and some of them have become eligible for the 4th dose. But the bottom line is that there is a significant proportion of the population, not just in New Jersey, but around the country, maybe more so in some other states, that refuse to get vaccinated, and no one will ever convince them that they should get vaccinated, unless maybe they get sick and survive their illness and decide maybe they should get vaccinated subsequently. The issue of a 4th dose, that's been making the news. It's been making news for a while. I saw some of the questions that came in prior to the panel discussion asking about that. There's a lot of interest in that. And right now, there has not been a recommendation for a booster dose. We don't really know when that should be given. We don't know what the durability of that dose might be. Pfizer, as you know, filed yesterday with the FDA for an emergency use authorization to administer a 4th dose in the 12 and over population. They're basing their data on a couple of studies from Israel. One of them showed that there was some efficacy using a 4th dose in not only preventing infection but preventing serious illness. And the other study was just among hospital workers, showing a good antibody response after a 4th dose compared to what happens with time after a 3rd dose. I think those studies are suggestive for the benefit of a 4th dose. But I wouldn't base policy on the U.S. based on 2 studies from Israel, frankly. And I think that particularly in the current environment where we have so little disease, because you can't keep boosting everybody every 3 or 4 months. It's not a good public health approach. So the question comes up is when and what period of time. And then there's a question of whether the vaccines that we're using are going to continue to be effective against subsequent variants. And we don't have any idea about that. So there are a lot of unknowns about when the booster dose, 4th dose might be, or second booster might be appropriate. We're just not there yet. But it'll be discussed by the FDA and their advisory committee, I believe, next month.
So we should, unless we're immunocompromised or have other issues, it sounds, in which case people should clearly talk to their doctors about what's appropriate. But it sounds like the rest of us should wait and see, not run out and think, a 4th shot is going to be better than not having it or something, or I just want to be extra safe. It sounds like we should be patient.
We have to be patient. I guess the good news is that some people are going to want to get it. But I do want to remind, if there's any health providers that are watching, that a 4th dose is not authorized yet. A second booster dose is not authorized yet by the FDA. And so they would be using the vaccine, if you will, off-label. And if any health provider would be giving that, then they would be potentially violating a contract that they have with the CDC. Which
anecdotally, I know is going on. But in any case, I want to talk a little bit about COVID in children. Ms. Kogan, tell us you've been on the front lines. There's this sense that, COVID wasn't dangerous to children. What have you seen?
Yeah, so I believe that was unfortunate information that tried to, it didn't help the cause of children getting vaccinated when that kind of information was being spread. Specifically, though, we did see less impact in children up until Delta and Omicron. There was a recent article just released that 1/3 of all U.S. child COVID deaths occurred during the Omicron surge. So, children are facing increasing risk, especially as we're now, abandoning mask mandates and the vaccination rates have stalled. So I think it's really concerning. I think it's important to have the conversation of, are we, ending these mask mandates way too soon when we don't know what's happening with this new BA2 variant, and the fact that, unfortunately, the Pfizer vaccine in children 5 to 11 is not as effective as we had hoped. Children under 5 are not even eligible for the vaccine. All of these reasons are part of the rationale of why Camden City School District and other urban school districts have decided to continue universal masking, because we need to protect everyone. We need to make public spaces safer for everyone, right? New Jersey residents and our children deserve to participate in school life and public life, but we also have immunocompromised children in school. We have children under 5 that are not yet eligible for the vaccine. We have, adults in our buildings that are immunocompromised. So we looked at all of the reasons in our particular community to keep mask mandates, to keep universal masking in place until we have more specific metrics about when it is really safe to drop these only protective measures that we have. And if you think about it, there are very few protective measures that we really have on hand, because school really should be considered a congregant setting. We spend so much time there together in large groups. And so while we don't sleep there, we certainly spend the bigger chunk of our day at school. And so, to be able to attend school safely and safely receive the most important services that we know kids need outside of learning, of certainly nutrition, healthcare, all the things that we provide at school, we are looking at continuing the universal masking as a protective measure. Also, just one more piece of that, and my school community that I serve is predominantly Black and brown children and families, and they have been certainly much more impacted by COVID than other communities. And so the one last piece I want to talk about that's so important is the grief piece, because we know that almost 200,000 children across this country have lost at least one caregiver to COVID, and that impact on our children. So why aren't we doing everything we can to protect our children while we're still in this phase of we're not sure where we're going yet?
And that's thousands of children in New Jersey. And I read one study that predicted almost all of them would be Black and brown children that lost a caregiver. It's shocking. I think you make a good point about schools being, a community space and a nexus for activity. I'm thinking of after school sports. I mean, it's not technically the school day, but children are gathering and at risk. We're definitely going to talk about monitoring. Don't go away. But before we do, I want to just touch on what is going on with the vaccine for the under 5 set. Dr. Bresnitz, can I come back to you on that? Dr. Bonamo, you might have thoughts as well, but I want to start with you, Dr. Bresnitz.
Well, in short, we're waiting. We're waiting to see the data from Pfizer initially. As you know, there was some move initiated by the FDA to potentially authorize the Pfizer vaccine as a 2-dose vaccine in anticipation that the 3rd dose would be authorized within a couple of months after initiation. This was sort of to get ahead of the game, if you will, and so that people would already have those 2 doses in their arms. Children under 5 would have those 2 doses in their arms, and then they would be eligible for that 3rd dose by the time it was authorized. But the problem was, it was clear that, according to Pfizer, the data wasn't supportive of that, and so they changed their minds. And now we're waiting for the data to be submitted sometime in April, and to reviewed and hopefully authorized and then made available, recommended by the CDC and the ACIP. But there, problem is, and maybe others can address this. There has been clearly surveys that have been done that many parents, caregivers, not just parents, but caregivers of children under the age of 5 who are not going to get their children vaccinated for a variety of reasons. And we can get a hint of that because the 5 to 11 population is under vaccinated and they're already eligible. And then we have, the chief medical officer, chief surgeon general in Florida, a public health official who says they're going to recommend that children in Florida, at least, shouldn't get vaccinated, which has caused a huge hue and cry. So there, yes, we're waiting for the data. We're hoping that it's going to show that it's a safe and efficacious vaccine in that population. It's quite a bit smaller. I think it's a tenth of the dose that was used in adults. But then we're going to face the problem of actually getting caregivers to actually vaccinate their children. Many of them think that or maybe have some safety concerns, but many of them also think that children don't get sick and their risk of getting COVID-19 or its complications are low, which is, as mentioned, not the case.
Yeah, that's disturbing because the numbers among vaccination numbers, the rates among children in general is so low. Do you, Dr. Rogers, I don't know if you want to speak to this as well. I'm thinking as someone who works with kids and families, what are your concerns for this group and how much stock should we be thinking about for this, putting in this vaccine, given that it's taken some time and has some issues?
Yeah, I think this is one of those areas where people have difficulty with ambiguity and uncertainty, because it is true, actually, that children, by and large, don't do as badly as adults when they get COVID. So the death rates are not as high as they are for adults, certainly not seniors with underlying chronic illnesses. On the other hand, there are a number of children who sadly die, but also children who get complications from COVID. And there's some evidence actually that it may be as much as 8 to 10% of children also get long COVID. And so we don't have a good way of talking to families about that, because you certainly don't want to overestimate the deaths so that people are just terrified for their children, but you also want to put into perspective that this isn't a completely benign disease for all children. I think that we also have, as we discussed earlier, just a tremendous amount of disinformation and misinformation about vaccinations. And it's compounded by the fact that we've had decades of misinformation about childhood immunizations, particularly as it related to vaccines causing autism and all of that, which we've just had a tremendously difficult time getting that nonsense out of sort of the public the public view. And so we do need to continue to put into perspective, but also educate families about the importance of vaccinating their children.
Yeah. And it seems like that's an ongoing process. It's obviously it doesn't pay off in the same numbers that, we had the numbers of people vaccinated necessarily as at the beginning, but clearly it sounds like it's still worth putting in that effort.
Leila, if I could just say one last thing, which is also we're fixed on these two vaccines. And the other thing that I'm extremely hopeful of is that there are another set of researchers that are actually working on a better vaccine, because we never talk about that, but we should be. Because as Dr. Bresnan said, it's certainly you can't keep doing every 4 months of vaccines. And, there was Salk originally with polio, and then we got Sabin. And so it isn't that we should necessarily feel like what we have today in terms of the vaccine landscape is what we have to have moving into the future, and that we can't do a better job.
Right. And yeah, I mean, these vaccines, as I understand, were specifically designed to prevent severe illness, hospitalization, and death, not necessarily designed to prevent the spread of infection, which we have clearly learned under Omicron. So I suppose there is room for improvement there, right? Dr. B. Bresnitz.
Denise used the term better. It's hard to get better from an efficacy perspective currently. I mean, the initial efficacy is 90+% for, let's say, the mRNA vaccines. Let's focus on those. There's been some waning after second dose, maybe even after the third dose. But it's amazing efficacy. In contrast, the efficacy for flu vaccine in any given year is at best 50%. And this past season, it was terrible. It hardly prevented disease at all. And so when we talk about the word better, yes, efficacy is certainly important, but it's also ease of use, it's cost effectiveness, it's durability, and does it address and prevent disease from novel strains? So there are a lot of factors that go into the concept of a better vaccine. We have great vaccines right now. We can always do better, but it's not just about efficacy and safety.
Okay. It's good to know. These nuances are tricky, but important. We have about 10 minutes left. I really want to focus on sort of two aspects: how we are monitoring, given that we're in a situation where the disease is still continuing at a much lower rate, but it is still out there. How are we monitoring it, and what should individuals, families, New Jerseyans, how do they calculate risk? Let's start with Dr. Bonamo. Hospitals, we watch hospital numbers all the time. How do you guys monitor trends, and what will you be looking at, and what's your advice to the general public as far as navigating these issues going forward?
So we really look at, certainly every day we look at the number of people that we're admitting, the number of people that we're seeing in our emergency departments who have positive tests and don't get admitted. So, but we continue to be very vigilant in the hospital setting. We continue to, exercise source protection with masking. We continue to use N95 masks in all the places that we need to, but universal masking throughout the facilities. We're still very careful when it comes to meeting sizes and social distancing and all those things. All the things that we learned when the pandemic was raging and it was new to us. All of those things are still very important. So our suggestion to people is to not let your guard down. We have 39,000 employees. We talk to them on a regular basis about still masking when you can. If you're going into the supermarket, it's probably wise to still mask, especially since we know we don't have numbers where we would really like them to be. So we think that people should not forget about hand hygiene, not forget about social distancing, not forget about source protection and masking. All those things that worked before will continue to work. And as far as families, they have to make some personal decisions, but I think they have to make wise decisions. If there's going to be a large family gathering, if people have the capability, they ought to be testing before, or perhaps they should be testing before and after if they have the capability of doing that. That's just that extra level of protection. And there are people who, of course, would never do that because they refuse to believe this is as serious as it is and was. But there are a lot of people who are doing things like that, and thank God for those people, because they're keeping a lot of other people safe by having that high index of suspicion.
Right. This negotiating risk stuff is new, I think, to a lot of people. Robin Cogan, please tell us how schools are doing, and what is the Swiss cheese model?
Yeah, so I love the Swiss cheese model, because the Swiss cheese model is every layer of Swiss cheese is another layer of protection that we have. And imagine, the holes in the Swiss cheese are pretty random, just as this virus is random. And every layer that we have in school to protect other people's children, because that's what's happening. We are responsible for other people's children. And so every layer is an added layer for protection, beginning with universal masking, certainly as we can, physical distancing, which truly is very difficult to do in school when we are full in and we don't limit classroom size anymore. Hand washing, certainly, all the way up to certainly vaccine for those people who choose to do it. And everything in between is what we do at school to keep people safe. What's happening at school right now, and this is what is so concerning, is that once the mask mandates were lifted and by the governor's executive order expiring, it was like Pandora's box opened up. And school districts, some are not even doing reporting. They're not contact tracing. They're not doing all the things that we have done for 2 years to keep people safe. And so that's a huge concern on the state level. We have to report on our district level. We have to report at the school level, at the district level, at the county level, and at the state level. The state level report is every week, the communicable disease reporting system. If schools aren't doing those things that they need to do, how are they then reporting to the CDRSS, right? We also report to the county. What's happened at school is that we have truly become the de facto health department because, as you had said earlier, our public health infrastructure is woefully understaffed. The structure could not at all bear the burden of what happened with COVID. And so school nurses stepped in truly as the de facto health department, doing the contact tracing, working with our local health departments to talk about outbreaks that were happening in school, really providing the on-the-ground data. So what is going to happen now? How are we truly going to be able to measure, transmissibility? Because we really aren't going to have the numbers anymore.
I think those are interesting questions. And I was thinking, Dr. Rogers, contact tracing, these backbone pieces of public health. One of the things, as Linda's, report found, we didn't really have the system we thought we should, and it wasn't connected with the hospital system or the health provider system. What's your sense on where we are with these resources now that we need to monitor this disease?
Well, I think people are actually less likely to comply with some of these resources now that we have the perception that we've turned a corner. So it's going to be even more difficult to do contact tracing because people are like, "Oh, we're over this, and we really don't need to be as vigilant." And I'm listening to our conversation and realizing that there are a number of people who are in our audience who think we are exaggerating, who think that, we're just sort of more of the Chicken Little, the sky is falling. And that's one of the biggest difficulties for us doing this work from a public health and a preventive health standpoint. We don't have a common set of facts anymore. And the data is very clear about how serious this disease is. And yet, I certainly hold myself somewhat responsible as a person who spent my career sort of working in communities at what seems to be my relative inadequacy at being able to help people understand what this data means and what the facts are, and that COVID is something that we must continue to take very, very, very seriously into the near future.
Yeah, that's a little sobering. Dr. Bresnitz, I'm going to let you finish this off here, but what's your assessment of our monitoring capacity? I mean, you worked with the state for years. Are we going to be able to do this, and what will it take? And what do families need to pay attention to now going forward?
Well, yeah, the monitoring in the state and in other states is quite robust. And right now we're focusing for the most part on severe disease. So as Dr. Buonanno mentioned, we're certainly monitoring hospitalization rates, admissions per 100,000 population over a 7-day period. Also still incidence of disease over that same time frame. Again, incidence per 100,000 individuals. And also the percentage of staffed inpatient beds that are treating patients with COVID-19. I mean, it's about making sure that hospitals can continue to provide the care to the community, not just for COVID-19 cases, but for other medical problems as well, which, as you know, was significantly neglected particularly in the first year of the pandemic. There are some novel approaches, wastewater treatment, looking for COVID-19 in wastewater. That's kind of a new source of information for making policy decisions. And all this surveillance stuff that we're talking about is really about what policy needs to change in the event that we have another surge, just like we had recently with Omicron. And, the real question would be, should we reinstating some of those policies that are now been laid aside? Wearing masks, social distancing, and so on, showing your vaccination cards. The monitoring is in place. The real issue will be, will there be the will to reinstate some of these non-pharmaceutical interventions
Right.
when those measures go beyond what we would be comfortable with?
And
convincing the public that, in fact, we need to reinstitute that. That's really the key.
Well, okay, and I just have to ask, given that may mean, say you were in Commissioner Persicelli's position and you felt that they did need to reinstitute that, how do you communicate that to the elected official? I mean, that's not necessarily an easy sell.
Well, you present the data, you compare it to what existed before, you compare that data to, for example, a year ago when you had a similar problem. You show what the problem was and what the interventions were at that time. And you have a discussion from a scientific and a public health perspective. What is the right thing to do? What are the policy options? Ultimately, at least in New Jersey and most states, it's the governor's decision on what the policy should be. And of course, that comes with blowback and pushback from a lot of people who would not want to and would resist any reinstitution of what they would perceive as interfering with their liberty.
Are you, just quick yes or no, everybody, I'm going to go around real quick. Yes or no, are you confident that New Jersey's government will be making the decisions based on, the best science they have available at the time? I'll start with you, Robin Kogan.
I don't know if they're going to have the best metrics available based on what we're doing. I just want to say one thing, and I know this is not a yes or no, but I heard this statement and it really stuck with me, that pandemics end psychologically before they end biologically. And we cannot let collective will overpower public health.
That's a really interesting point. Yeah. Dr. Bonomo, what's your confidence?
I think I said what Robin just said earlier. We want it to be over, and that's why we're believing it's over. I believe that I would hope that our legislators just slow down a little bit and not let that psychological will take over, because then even people who are willing to do what they have to do may let down their guard if they actually believe there's no need to do anything.
Right.
And I worry about that.
Right. Dr. Rogers?
I'm just going to say I hope so.
Fair enough. And Dr. Bresnitz?
Well, I believe that the Communicable Disease Service and Department of Health will give their advice based on the science. They're not afraid to do that. They will give that advice to Commissioner of Health. The Commissioner of Health will pass it on to the governor and his staff. And then it'll be up to the governor to make the decision, understanding that, as I said before, that there may be some pushback. The good news for the current governor is that he's in his second term. And so I think that he can make a decision that might not be palatable to some of the public.
Yeah. Pushback is relative, right?
Yeah.
Thank you all very, very much. I know there are things we didn't cover, long COVID, workforce issues, but there's fodder for more roundtables. I'm going to send it back to John Mooney, but thank you, audience panelists, for all your time and good thoughts. And thank you, audience, for joining us today.
And I want to also thank you, Lilo, for a great discussion, a sobering discussion, I might say, in listening to it. It sounds like we have a long way to go, and I'm glad we're having these conversations. So thank you very much. For those who may have come in late, we are, as we mentioned earlier, we taped this entire session from the very beginning, and we'll be providing that to all registrants. So look for that in your inboxes, and please also share it. we have found that a lot of attention is paid to these after the fact in terms of circulating among peers and friends and family. So please do share it once we post it into your mailbox. And again, we will be holding more virtual roundtables around living with COVID. As mentioned, our next one will likely be in May, focusing on mental health. We'd also hope to do a roundtable on education and as well as on the workplace. But as this conversation showed, we have some time because this is going to be an issue we're going to be living with for a long time. So thank you all for joining us and staying with us. And again, thank the panel and Lilo, and safe travels, everyone.